There are over 1 million registered nurses in the United States who hold active licenses but refuse to work at the bedside. We hear constantly about a massive nursing shortage, but the math reveals a different reality. We aren't failing to train enough healthcare professionals. We are failing to keep them in the hospital. The daily environment they are expected to work in has become intolerable. This chart breaks down exactly why registered nurses are leaving their primary positions. Look at the top two bars. 65.9% point directly to burnout, and 51.7% cite inadequate staffing. When hospitals don't schedule enough staff, the nurses who are on the floor are forced into grueling 12-plus hour shifts with an unmanageable number of patients. This quantitative problem, too many patients, too few nurses, creates a very specific psychological trauma known as moral distress. That's the emotional pull of knowing exactly what care your patients need, but being physically unable to provide it because you are stretched too thin. The labor pipeline is working, but the healthcare system is suffering from a structural failure to retain the talent it already has. When staff are stretched to the breaking point, care gets rationed. In clinical terms, this is called missed nursing care. It means vital signs aren't checked, medications are delayed, and patients wait for basic help. This flowchart illustrates how dangerous that becomes. Starting with a baseline standard of 1 nurse to 4 patients, the math gets grim. For every additional patient added to that workload, the likelihood of a patient dying within 30 days increases by 7%. That increase in mortality is driven by failure to rescue events. Nurses act as the primary surveillance system in a hospital. When they have too many rooms to cover, they lack the time to detect the subtle early signs that a patient's condition is deteriorating until it's too late to save them. Chronic understaffing drives a lethal patient safety crisis that requires a systemic intervention. To fix a structural failure, you need a structural tool. For hundreds of thousands of nurses, that intervention is the collective bargaining power of a labor union. The primary mechanism unions use to break the burnout cycle is the demand for legally mandated minimum safe staffing ratios. By embedding these specific nurse-to-patient ratios into a binding legal contract, hospital administrators lose the ability to arbitrarily stretch their staff to cover operational gaps or save money on a given shift. Unions also tackle retention through direct compensation. Data shows unionized nurses secure wage premiums between 5 and 8% higher than their non-union counterparts, alongside comprehensive health and retirement benefits. They establish strict rules prohibiting mandatory overtime as well, ensuring that a hospital cannot legally force a nurse to stay for an extra shift when they are already exhausted. Collective bargaining takes the theoretical concept of patient safety and turns it into an enforceable labor standard, protecting the nurse's license and the patient's life. But inserting a union into a hospital ecosystem introduces immediate administrative friction. There is a direct financial cost to the worker. Nurses must pay mandatory union dues deducted directly from their paychecks to maintain this representation. Union contracts also rely heavily on seniority. This framework often rewards tenure over clinical excellence, meaning promotions and raises are based on years served rather than performance. It also makes terminating poorly performing staff incredibly difficult. Then there is the ultimate leverage, the strike. A work stoppage leaves nurses unpaid and actively disrupts hospital operations, forcing administrators to scramble for expensive temporary replacements. The data on these disruptions is severe. During nursing strikes, in-hospital mortality and 30-day readmissions can temporarily spike. While unions provide crucial systemic protections, they also introduce rigid administrative hurdles and carry severe short-term risks during labor disputes. We have to weigh those short-term operational disruptions against the long-term empirical data on how unionized hospitals perform overall. On the employment side, unionized facilities consistently exhibit better nurse retention, safer daily workloads, and significantly lower rates of moral distress among their staff. In unionized hospitals, patients fare better on 12 of 13 outcomes sensitive to nursing care quality, like preventing urinary tract infections. Crucially, unionized environments also show measurable reductions in failure to rescue rates and lower patient mortality following acute heart attacks. Despite the administrative friction and the very real danger of strikes, nursing unions effectively intervene in the root causes of both the retention crisis and the patient safety crisis. brutal working conditions drive nurses away from the bedside. Understaffing hurts patients. Unions offer a mechanism to enforce safety. Hey, thanks for watching my YouTube channel. Don't forget to like and subscribe and leave a comment. Let me know what topics you want to see more of and how I can help you become the super nurse you were born to be. I hope to see you here again real soon.